Today I'm going to talk about diet therapy in IBD, and I wanted to start it off with diet therapy in IBD, specifically looking at the mechanisms of action of diet in IBD. And this is quite important because by looking at how we think diet is transforming patients who have IBD and their disease process, we actually can learn by it and improve not only a patient's outcome, but hopefully those individuals who aren't using dietary therapies outcome as well by learning from that experience. And what's really important to realize is that diet is truly transformative. We have been using dietary therapy here at Seattle Children's for a number of years, and we have individuals who have used diet alone to successfully treat their IBD. And we have individuals who have used medications for years where the medications aren't doing the trick themselves, and we need to look outside of the standard box of treatments and find therapies like diet which focus on a different area than our medications to get improvement. And that's another significant area where we use dietary therapy. So when we look at dietary therapy, what do we have to really focus on? Well, before we actually look at the therapy itself, it's really important to understand what the inflammatory bowel disease paradigm is, to look at the different components. And there are three main components when we talk about IBD. One is the intestinal microbiome, or the bacteria within our GI tract. Another is the mucosa itself, that barrier that keeps out the vast majority of bacteria from invading our body. And then finally, the immune system, the cells that protect our body from infection and who are instigating the inflammation within the bowels itself. And then we're going to look at how diet actually modulates the fecal microbiome. But not only modulating the fecal microbiome, but also the intestinal mucosa, that barrier that I just spoke about, as well as the immune system itself. And then finally, we're going to examine our experience and the research with diet in inflammatory bowel disease. But you may ask, why is diet so important? And how do you know that diet and environment is implicated? And it's studies like this that focus on the incidence of inflammatory bowel disease that really tell you that environment and diet play a very important role in IBD. And this is a study in pediatrics, but there are very similar studies in adult medicine as well. And it shows that the incidence of inflammatory bowel disease is increasing over time. And this is a study from Scandinavia, so it's a very homogeneous population, a population that doesn't change much. And you can see that from the 1980s up to 2014, there has been this incremental rise in the incidence of IBD in that population. And we see that here at Seattle Children's. I started here about 15 years ago, and the amount of IBD we saw then as compared to now has dramatically increased as well. And it's not only in areas such as North America or Europe, which are the areas that have really been focused with inflammatory bowel disease, but it's areas that we once did not see or hear about IBD. So in Southeast Asia, countries such as China and India, which had no or very few cases of IBD 20 years ago, are now seeing a large increase in their IBD as they become westernized and as their foods change. So before we talk about disease, we have to really understand health. When we talk about the intestines and we talk about health, we're really, again, looking at those three main components. We're looking at the microbiome, the bacteria within us, the mucosa, that barrier system that keeps out the vast majority of the microbiome, and the immune system, our body's defenses. And in health, these areas, these three main components, live harmoniously together. So they don't have any negative interactions with each other. And you get a bowel that looks like that, nice, happy, pink. In inflammatory bowel disease, something has shifted, something has changed, and the microbiome has become despotic, or what we define as bad. The mucosa gets broken down, so that barrier system is not intact anymore, and the bacteria can get much closer to the immune system and instigate an inflammatory process. And there are a number of risk factors that we know occur in IBD. We know that genes are very important in IBD, but this is not a genetic disorder such as cystic fibrosis or Alagille's, which is a single gene that causes a disorder. This is a disorder that's made up of potentially over 200 different genes, each individual likely with one gene that is causing the problems. And these genes, for the most part, are dealing with how our immune system interacts with the microbiome, those bacteria inside. And we know it's not a genetic disorder in the same sense as the other disorders, because you can have these genes and not develop inflammatory bowel disease. So again, we need to focus on environment as the major trigger of IBD. Antibiotics are a significant trigger in IBD, and antibiotics, as we all know, affect the microbiome, the bacteria within our GI tract. There's actually an 84% relative rate increase in the development of IBD, in pediatric IBD, when you take antibiotics. And to give you a sense of that number, if you are a smoker, you have a 20% relative rate increase in the development of lung cancer. So it's a strong association between the antibiotics and IBD, and that's true also in the adult population as well. And then Western diet. The changes that we've seen in our diet, we know affect all the areas that are important in IBD and in intestinal health. So we know that a Western diet affects the microbiome and can cause a dysbiotic microbiome. We know that a Western diet can break down that barrier and cause the bacteria to get much closer to the immune system. And we know that diet can cause inflammation in and of itself. And when all these things come together and you start to develop IBD, you get a colon that looks like this. You can see the ulcerations, you can see the irritation, and the symptoms that are associated with IBD, the abdominal pain, the diarrhea, the issues with weight gain, and anemia, those are all interrelated with this process. So why look at diet? And which diet should we look at? Obviously, I'm going to tell you I'm a little biased. We look at the SCD, and we look at the SCD because it's a diet that has been best studied. It's also been around for the longest time period. It's a diet that was started in the 1930s by Sidney Haas, and he did not mean necessarily to treat inflammatory bowel disease. He was using it to treat celiac disease. And it worked phenomenally well for celiac because it removed all the grains, and wheat obviously is a grain. But then he took care of a child, the daughter of Elaine Gottschall, who had ulcerative colitis. She had been told that she was supposed to get a colectomy, and the mom did not want that, and therefore she went to see Dr. Haas, and they put her, or he put her on the SCD, and she did well. She then popularized it and refined it and wrote a book. And it's really been outside of the medical sphere since then. What this diet does is a number of things. It restricts certain foods and it focuses attention on other foods. And it's these changes that are most likely the cause of the improvement that we see clinically. With the restrictions, it takes out all grains. It removes all sweeteners outside of honey. It takes away all milk products outside of hard cheeses and yogurt, as well as taking out the vast majority of food additives that we have in our diet today. What it does add in is whole foods. So it focuses on meats and fruits and vegetables, as well as a yogurt that's fermented for 24 hours, which has a much higher probiotic count than most yogurts and removes the vast majority of lactose. So how does diet work? What do we think diet is doing to our IBD paradigm? Well, it's doing a number of things. It's taking the dysbiotic bacteria and hopefully changing it to eubiotic bacteria or happier bacteria. And I promise you, I will show you the data. And it takes, and diet, by removing some of the things that we think are breaking down the mucosa, it allows that barrier to be put back up and keeping away the bacteria from the immune system. And it is likely also to have a direct effect on the immune system itself. So let's go through each one of those areas step by step. Let's first talk about intestinal microbiota. And again, Dr. Lampe is a world-renowned expert on this. So if I say anything that is not what she says, I would go with what she says versus me. With that being said, it is a fascinating area, and it's an area that we are learning a lot about, but really the focus has been increasing over the last decade, and we have a lot more to learn. We know that there are likely up to or around 100 trillion microorganisms, and these are bacteria, viruses, fungi, other eukaryotes, and it's a diverse ecosystem, just like the world that we live in today that has many different animals, mammals, the same thing that occurs in the microbiome. There are many different organisms, single cellular for the most part, that live within. And within our GI tract, there are up to around 400 or so different species that can live within our GI tract. But each of our microbiome is different. Just like a fingerprint, our microbiomes are unique to us, but they're only unique to us for a moment in time, because anything that changes our environment and our internal environment is going to change the microbiome. So the microbiome is plastic, it's very changeable, and it changes because the microorganisms are adapting to our body, which happens to be their environment. And the picture on the bottom is what I really like to focus on, because it really emphasizes the diverseness of the microbiome. There are many different types of microorganisms in there, and they're not static. They're not just sitting there. They're actually very bioactive, and they're communicating with each other, but they're also communicating with us, their host. And in IBD, something changes. Something changes to the microbiome. The microbiome, again, becomes despotic. And again, we know what we think a healthy microbiome looks like, and we call the microbiome despotic in IBD because it's changed from what we are considering healthy. In IBD, you get decreased biodiversity. So the number of species within an individual's bowels is decreased substantially. You get decreased commensal bacteria. You get a higher concentration of mucus and mucosal associated bacteria. And this is an important point, again, because that mucus is that barrier that keeps the vast majority of bacteria away. And there's an increased number of mucolytic bacteria, again, breaking down that barrier to the immune system. And finally, you get a reduction in the abundance of bacteria involved in butyrate and propionate metabolism. And these are what we call small chain fatty acids, are very important in overall health of the GI tract, specifically the colon. So how does diet really change the microbiome? It's a concept that we know is true through multiple basic science research. But in a conceptual way, you can look at the organisms within our GI tract as single cellular animals. And just like multicellular animals, the tiger, the dolphin, the panda, the gorilla, the bat, the cow, different organisms like to eat different things. And so if I gave all these animals hay to eat, we would not be surprised if we saw maybe a number of those animals die off or decrease in number. And then you'd get a plethora of cows in your yard. So again, in the same way that multicellular organisms such as these depend on the foods they eat, single cellular organisms also depend on the foods that they are provided. So just like the multicellular, if you were to give single cellular organisms a specific food, let's say fruits and vegetables, you would see a significant shift in the organisms that would be able to metabolite these foods and therefore change your microbiome appropriately. And we know this from a number of studies, and one of the more interesting studies is by a group by Sonnenberg, and they've done many studies, and one of their studies was quite fascinating. They went to different areas of the world. They went to the Amazon, to Africa, areas in Europe, and looked at different communities, industrialized versus agricultural. And what they found was that the microbiome of different groups changed substantially as areas become more industrialized. And they came up with this hypothesis that over time, over the last 10,000 or so years, we've probably had a number of microbial extinctions based on the foods that we are eating. Again, more industrialized, the less and more processed the foods, the less diverse the individual's microbiome. And we know that, again, diet plays an important role from a number of basic science studies. And this is a study by Carrageenan and colleagues where they try to ask the question, what's more important in terms of your microbiome? Is it the foods that you're eating, the diet, or is it your underlying genetic background? And what they did was they took diets, or they looked at diet's effect on the fecal microbiome in 5 inbred species of mice. And these mice were deficient for genes that were relevant in host microbial interaction. So genes that were relevant in conditions like inflammatory bowel disease. And they gave them a high-fat, high-sugar diet or a low-fat, high-fiber diet. And what they found was that diet shaped the gut microbiota similarly across genetically diverse hosts, meaning that diet was the major driver. One of the interesting things about this study as well were that most of these changes were reversible, but the abundance of some taxa depended on diet history. So meaning what you did earlier really also affected what organisms you had later, or the abundance of those organisms. And we know that this is true in humans as well. And this is a study by Rothschild in Nature. And this is a study that looked at environment and genes in the human gut microbiome. And what they did was get different populations. And this study was done in Israel. They looked at Ashkenazi Jews, Sephardic Jews, Yemenites, individuals of Middle Eastern descent and North African descent. And they looked at their microbiome as well as environmental factors. And what they found, similar to the animal studies, was that really genetics did not play a strong role in determining your microbiome, but your environment did, and diet being one of the more important components of your environment. So what about the diets that we use in inflammatory bowel disease? What about the specific carbohydrate diet? Well, there is emerging research that's being done, and this is a study by Walters and colleagues that looked at intestinal microbiome in the SCD. And this study was done in patients who had Crohn's disease, but all the patients were in remission, meaning that they were already doing quite well. And they put them either on a low residual diet or the standard diet that we usually put people on when they're having active Crohn's disease, or they put them on the specific carbohydrate diet. And what they noticed was that the diversity and the types of organisms were much greater in that of the SCD versus the low residual diet. But what we also want to know is what happens with actual active disease. So we see a change, but is that change correlated with improvement? And so we did a prospective study here at Seattle Children's where individuals who had active IBD went on to the SCD. And this is just one of the patients. And what we saw for this patient was at baseline they had a large amount of something called E. coli and Rhumatococcus ganavis, two organisms that are implicated in IBD. And by changing the diet, we saw a significant shift in the amount of both of these organisms. So from 12 and 15% at baseline down to 0.2 and 1.9% at 12 weeks time. And we did this with all the patients, and I would love to say they all shifted in the exact same way, but they didn't. They all shifted, which is probably the more important concept, but they all started off with a different microbiome, and so the shifts were different in the different patients. But again, focusing on the fact that the SCD has a major impact in what the microbiome is. But there's a dilemma, and this dilemma is a fascinating dilemma. We also have a treatment called exclusive enteral nutrition, and Dr. Lee will be talking a lot more about that later on today. And exclusive enteral nutrition works extremely well for Crohn's disease. And it gets people into clinical remission as well as decreasing the inflammatory burden. But what we expected to see with EEN is actually the opposite of what we actually see. So when we look at the microbiome, we actually see a decline in the protective gut bacterial species, as well as metabolites that, again, are associated with improvement in Crohn's disease. And this study has been replicated a number of times. So we get the opposite effect of what we're expecting, which tells us that maybe the microbiome is important, and maybe it's a question of shifting the microbiome one way or the other, Or it may be that we also have other components that are important in inflammatory bowel disease in terms of making patients improve. So that brings us to the next area, the intestinal mucosa, the barrier that keeps the vast majority of bacteria away from the immune system. And we know that this is such an important component of IBD from a number of basic science studies that we'll be going over shortly. We also know that diet has a big impact in this area. And things such as high-fat, high-sugar diets, emulsifiers, including maltodextrin, CMC, and polysorbate 80, Carrageenan, caking agents like titanium dioxide and microparticles have all been associated with breakdown of the mucosa in IBD. Part of the difficulty with diet research and any condition, including IBD, is that it's not done that much. And we know about these studies because somebody took the time and effort to do that research. But the vast majority of foods and food additives are not actually examined for different conditions, including IBD. So there may be a lot more additives that are problematic that we just haven't researched as of yet. And an important concept here is that these food additives are fairly ubiquitous. So even though you may not be thinking you're eating any of these because you don't look at CMC and the packaged ingredients, the vast majority of processed foods have these food items in them. They add to taste, they add to shelf life, things that are important to the food industry. So before we talk about the basic science, let's talk a little bit about that barrier in detail. And so the barrier, again, keeps the vast majority of organisms away from the immune system, which is down here. And the barrier is made up of a number of components. One is this mucus layer. And this mucus layer is extremely important because, again, you have about 100 trillion organisms right here. And then you have this mucus layer, which is 9 microns thick, so microscopic. But it keeps the vast, vast majority of organisms from actually getting in and invading the body. And then below the mucus layer, you have this epithelial layer. And these are cells lining the GI tract. And they're held together with something called tight junctions. Proteins that allow the bacteria or don't allow the bacteria to invade into the body itself. And below that is the immune system. And the immune system, even though it may not be inflamed, is always active. And what the immune system is doing is sending cells or components of cells out to grab the bacteria to see what's there, to see if it's an inflammatory bacteria, see if they need to upregulate. And again, this allows the body to deal with the microbiome in a safe way. So again, we know from a number of studies that diet impacts the microbiome. And in this study by Martinez Medina, they noticed that a Western diet, a diet high in fat and high in sugar, actually increased E. coli, again, one of the organisms that is possibly triggering the immune reaction in IBD. But it doesn't only increase the E. coli. Again, it affects that barrier system. And you can see here in this picture, animals fed a conventional diet had no increased Claudin-2, while animals fed a high-fat, high-sugar diet had increased Claudin-2. And you may be asking, well, what is Claudin-2? Claudin-2 is a pore-forming protein. And having an increase in Claudin-2 allows the gut to become leaky. And so again, this leads to that proverbial leaky gut that we see in inflammatory bowel disease. It also decreases something called MUC2, and MUC2 is an important component of that mucus layer. So by decreasing the MUC2, it decreases that mucus layer and again allows the bacteria to get much closer to the immune system itself. And it would be great if it was only a high-fat, high-sugar diet, and we just take that out. But again, there are many components to our diet, and the emulsifiers are an interesting area of research and an area that has been researched more than other food additives. One of the more common ones is maltodextrin. It's a chemically enzymatically processed starch, and it actually started to come into our diets in a significant amount after World War II. And it's felt to be safe by the FDA, and it's, again, in a large number of packaged products. And what Nickerson and group did was looked at the effect of maltodextrin on the lining of the GI tract. And you can see here in the control group, you have these little red dots, which are the bacteria sitting here. You have the epithelial cells sitting here. And in the middle, you have that mucus layer. And you can see a few red dots within. But when given maltodextrin, the mucus layer gets broken down fairly significantly, and you get the bacteria getting much closer to the epithelial layer, and again, being able to instigate an immune reaction. And there are other emulsifiers on the market, CMC and P80. And this is in a study of something called interleukin-10 knockout mice, so mice that are predisposed to developing colitis. And what you see here is a very similar picture. You see a breakdown of the mucus layer with CMC and P80, again allowing organisms to get much closer to the epithelium. It also increases intestinal permeability as compared to water, again leading to a proverbial leaky gut. But what was interesting about this study was what they saw with regards to the incidence of colitis. So again, these animals are genetically predisposed to developing colitis. And if they were just fed water, about 40% of them would develop the inflammation within the colon. But when you added in CMC and P80, that number actually doubled. Again, suggesting that in our world, we've had the genes that predispose us to developing things like inflammatory bowel disease for millennia. But we didn't have the environmental change to bring that actual inflammation about. And there are other things that are added into the diet. Carrageenan is a polysaccharide derived from red seaweed. It's a food additive, and it improves texture of food. It's felt to be the degraded carrageenan, which is linked to ulceration and inflammation in animal models. And it's estimated that we probably get about 50 to 150 milligrams per day within our diet. And I wanted to show you a human study because there are so few of them done with food additives, but I thought this study was intriguing for a number of reasons. One is that they were able to get it through the IRB to do. The other is the results of the study. So the reason why it's fascinating is that it took individuals who had ulcerative colitis who were clinically doing well. So they had no symptoms, they were not flaring, and then they gave them either placebo or carrageenan, about 100 milligrams. So what we probably all see in a day. And they looked at them over a year time, and they looked to see if they relapsed. And you can see here in the Carrageenan group that they relapsed at a much higher rate than that of the placebo group. Again, pointing to the fact that the foods that we eat have a direct impact on the well-being of our intestines. And there are likely direct effects of inflammation. There are components within the foods that we eat that we know are directly pro-inflammatory or anti-inflammatory. And we see this in a number of different foods. And so these items here in the pro-inflammatory are items that we see in grains, such as wheat germ gluten and amylase trypsin inhibitors, which have been shown to affect cytokine levels. And there are also anti-inflammatory foods like isothionates, polyphenols, and resveratrols. And these foods are found in fruits, vegetables, nuts, and again, probably having also a direct effect on the inflammatory process itself. So now we have this mechanism by which we think the diet is working. What are the studies showing us that diet does work? The research is growing. We're still in the infancy with regards to a lot of it, but there are a number of large multi-center studies that are being done right now. But there is good evidence from multiple centers that diet, and specifically the SCD, have a positive impact. And I'm going to walk you through some of these studies. This was our first study. This was a study in Crohn's disease, and this study looked at 7 patients who had decided to do dietary therapy as opposed to medication therapy. And when they started, they had mild up to moderate disease based on something called the Pediatric Crohn's Disease Index. And you'll see that referenced a number of times in the slides that we're going to be going over. And below 10 is remission. Above 10 to 30 is mild disease. Above 30 is moderate to severe. And you can see after 3 months, they came back asymptomatic. But what really caught my eye and my colleagues' eyes was what happened to the inflammatory process. So all of these individuals came in, except for one, with elevated CRP. And what you can see is that after a 3-month period, the CRP normalized. So it wasn't only making patients feel better, it was actually reducing the inflammatory burden in their bodies. And so we move forward to see if this could be generalized to a larger population. So we sent out a survey to individuals who had been doing the SCD, and this was a survey of over 400 individuals. And what we found out was that it did make people feel better. And you can see that it reduced abdominal pain, diarrhea, bloody stools in the majority of patients. But what was also important to note is that it didn't work 100% for all patients. And that was an important learning experience for us as well. And there were other groups that did similar research. This is a group from Stanford that looked at the SCD with or without immunomodulators over a year's time. And what they did was follow their clinical and laboratory scores. And you can see that not only did they actually feel better, but their inflammatory burden as measured by ESR also normalized. And what they also looked at was what happened after individuals liberalized the diet. And for their group, the majority of individuals actually maintained decreased inflammation, which points to the question of how can we improve on the knowledge we have with the SCD, and how do we adjust the diet to not only maybe improve the inflammation, but also make it sustainable long-term for our patients. Another study, and this looking at a slightly different angle of the SCD, was a study by Stan Cohen's group in Atlanta. And they looked at 9 individuals with active Crohn's disease who went on to the SCD and had no change in medication. 4 of them were on immunosuppressant, 1 on mesalamine, and 1 on budesonide. And they looked at symptoms in labs over 12 and 52 weeks. And what they noted was that individuals, just like what we saw, improved, and that the majority of individuals maintained that improvement over the full 52 weeks based on clinical score. Also, their inflammatory markers improved significantly over the first 12 weeks, and for the most of them maintained that improvement over the full year. What they also did was look at something called the Lewis score. And the Lewis score is a score of the mucosa and inflammation in inflammatory bowel disease. And what they did see also was that the inflammatory process based on the Lewis score improved as well, with 2 of the 9 individuals having significant improvement. We ourselves have done a number of small case series with endoscopy and colonoscopy showing that SCD can also have normal mucosa for patients. So we move forward with a prospective study of the SCD, and similar to previous studies, there could be no change in medication. We followed them for a full 12 weeks, and we looked at their clinical and laboratory response, but also their microbiome, as I had mentioned before. And what we saw was very similar to our prior experience, with a significant improvement in clinical scores. Here, patients had mild and moderate disease, and as a group, by 12 weeks, they went into clinical remission with a PCDAI and a PUCI score less than 10. We also saw a dramatic improvement in the inflammatory burden, with the majority of patients normalizing the inflammatory process as based on CRP, sed rate, and calprotectin. But it's important to look at not only groups, but the actual individuals themselves. And again, this study had 12 patients. And what you'll notice is 2 patients weren't able to maintain the dietary therapy. It can be a challenging diet to sometimes follow, and definitely support is key for success. We also noted that 2 individuals actually didn't respond to the diet. And this is important too, because when we make decisions in inflammatory bowel disease, we want to base our decisions on how the individual is doing, not necessarily looking at groups. And so that's important to keep in mind. In terms of the inflammatory process, you'll notice that there are different markers for the CRP here, but again, the majority of individuals had improvement or normalization of their inflammatory markers based on CRP. When we looked at calprotectin, or a stool inflammatory marker, we also saw a significant improvement for the majority of individuals. There were 2 individuals who clinically responded and had improved CRP, but did not have improvement in calprotectin. One of the individuals we checked about a month later, and he then had normalization of the calprotectin, so not 100% sure what happened there. Another individual we noted to be eating a number of foods off of the SCD, and that's how we explain that. But there are also 2 individuals who didn't respond to the dietary therapy, not have normalization or improvement in their CRP. And as I had mentioned before, we saw a dramatic shift in the microbiome. The organisms for the majority of individuals changed dramatically with diet introduction. And we move forward with a diet blinded study. And we did this study because it's important for us to understand the different aspects of the SCD and to see if we could potentially liberalize it. We had the same criteria for enrollment. Individuals went on either the SCD with oats and rice, or a modified whole foods. And the foods were chef provided, and they also had a free food list. And then we looked at them clinically, laboratory, as well as the fecal microbiome. And we're still analyzing this data. But what we can see here is that the majority of individuals improved clinically, no matter what diet they went on. So that really points to the fact that diet matters in terms of symptoms. And we want to encourage even those individuals who don't want to do dietary therapy to improve on the foods that they eat to make their bowels feel better. We also saw, for a majority of individuals, improvement in inflammatory response. What was interesting is that 2 individuals who had the highest inflammatory burden went on to the whole foods diet. And we see, even going on to the whole foods diet, you get improvement. You don't necessarily get normalization of the inflammatory burden, but you get improvement. Again, focusing on the concept that even if you don't want to do SCD or SCD-like, eating a healthy diet still matters. And there are other dietary interventions. There are diets that have been based on the SCD, such as GAPS, Makers, Autoimmune, and Paleo, as well as IBD Aid. But unfortunately, these diets haven't really been studied. In addition, there are other diets, such as the Crohn's disease exclusionary diet, which have been studied, but are proprietary, so we don't have the details of the diet at hand. And then there are other diets, such as the IgG4 diet and FODMAPs, that have been studied well and seem to help with symptoms, but not the inflammatory burden. And then lacto-ovarian vegetarian diet. There are a few studies, primarily coming out of Japan, suggesting that there is benefit when somebody is already in remission. But the positive thing is, I think, the viewpoint of medicine is starting to change, and starting to change in a fairly big way. We now have a number of multi-center studies looking at SCD. The pediatric study is the PRODUCE study, and that's a study that we, with Cincinnati Children's and about 10 other centers, are doing, as well as the CD-DINE study, which is an adult study of the SCD, looking at it compared to the Mediterranean diet. So I think we're going to be learning a lot more. In addition, we have a number of smaller studies here at Seattle Children's, including a low animal protein diet and a reversed engineered EEN diet that Dr. Lee is leading here to help better define the important components of diet in improving inflammation in the GI tract. So what do we tell our patients? What do we advise them? Well, it really depends on the individual and what is going on and what they can do. You don't necessarily want to have somebody go onto the SCD if they're not going to be able to maintain it, or if they don't have the support that they need to do it. But even if they aren't able to do something like the SCD, it's still important for us to encourage a healthy diet because in the end, diet matters. Thank you very much. So I think we have time for a number of questions, if there are any questions out there. Yes?
When you're talking about the SCD, have you ever used like
Mm-hmm.
limiting certain foods to a certain number of times per month or things like
Yeah.
that. Is that something that you've ever gone?
Yeah, no, absolutely. And so the interesting thing about the SCD is that we've learned a huge amount from kind of individuals' experiences, and that's really important. But we haven't until just recently had a organized look at how to do the SCD. Within our practice ourselves, we started doing the SCD as Elaine Gottschall describes. I have to say that we probably have changed our practice significantly, where we go through the stages much quicker, probably over a week or two process, and Heather is going to talk a little bit more about that for a number of reasons. One is that we are seeing clinical improvement with that and laboratory improvement with that. And two is that we are concerned, especially in the pediatric population, of significant weight and weight loss. With that being said, we adjust that depending on the situation, depending on the patient and how they're doing. So if somebody is not having the response that we want, we may draw that out a little bit longer. Other?
On your website, the website, is information about your Pro study, and I think you're studying some patients that are on the SCD diet and some that are on the modified SCD diet.
Yes.
So, any results back from that yet?
You might get me in trouble. So the Pro study is a great, obviously I'm biased, but it's a great study. The reason it's a great study is that it is taking the individual and having that individual go back and forth from the standard SCD to the modified SCD. And that will allow us to better understand, if liberalizing the diet is a good thing, or if a liberalized diet may work for some. But we're also checking the microbiome at the same time, and metabolomics and a lot of basic science studies. That will help allow us to understand the changes that we're seeing with each of these different diets and correlate that with the symptoms and the inflammatory burden. So it's a very comprehensive look at SCD on an individual basis. And I apologize. What was your question again? Go ahead. Oh, the data, yes. So I can't actually say the data as of yet, but I can say that I'm happy.
But when is it coming out?
Well, as you can imagine, it takes a while. We probably will be recruiting for another year, so it'll be after that.
You suggested that high fat decreases or causes mucosal breakdown. Is there any differentiation in the fats?
So it's a high fat, high sugar. So it's most likely there. So there are probably different mechanisms by which that works. The most important mechanism is likely related to the microbiome itself. So when I talked about the dysbiosis, we talked about mucus-associated bacteria, so bacteria that actually get into the mucus and survive there, and mucolytic, so that they break down the barrier. And it's likely that high-fat, high-sugar diet increases those types of bacteria and allows for the breakdown of the barrier. That's a great question. To my knowledge, that question hasn't been researched. I think it's more likely quantity as well as quality of the fats that we're seeing in our diet.
In these studies, how do you monitor the compliance even when simple things like swallowing pills, up to 40% of
Hmm.
chronic patients
Absolutely.
don't take their medications. In those patients where there wasn't any response, is it
Yeah.
because of non-compliance or?
Yeah, and that's going to be a important aspect of dietary therapy, and that's something that we're hopefully going to be working on with upcoming studies. So what I would say in terms of compliance is that it's individuals who do dietary intervention, who want diet as their primary therapy, are very motivated. And the children who do the dietary therapy are actually very motivated as well. Compliance will be an issue, and that's why in close follow-up is always important. So we don't know if in the studies people are not responding to dietary therapy because of compliance or because of the process not responding or individuals not responding to the dietary change. And we keep that in the back of our minds, but there's not an easy way to necessarily answer that question.
One comment.
Oh, yeah.
So a lot of these trials that are happening, or the adult trial that's happening, they will deliver food to you. So they'll deliver food for 3 meals and 2 snacks per day. And this issue of compliance is really important. So we have data that Dr. Suskind and our team have collected. So we have data for what people eat on sort of a patient, family-driven specific carbohydrate diet, and also what they eat with a chef-delivered specific carbohydrate diet. So we have a little project ongoing right now led by one of our residents, and we're going to compare dietary intake if you were delivered food versus if you and your family prepared the food. And I think it will be interesting because I completely agree with you that compliance with diet is really difficult to fully ascertain, and it's critical for understanding the results here. You can control diet. You bring them in somewhere and you house them for like a week or 2 weeks and feed them, and you know exactly what they're getting. But that's not real life. So for us to think about compliance and how that plays a role is extremely important.
Have you always seen similar responses in Crohn's and UC to SCD? That's what your data shows.
Yeah. So we also have a very large clinical program with probably over 100 kids on the SCD. For the most part, seeing similar response. I think with the multi-center studies with larger patient cohorts, we'll be able to better define that, but we're seeing improvement in both groups.
With respect to the microbiome analysis,
Mm-hmm.
are you getting to the genus and species level with respect to what's remission and maintenance, et cetera?
Yeah, so and we are looking at genus and species. The issue, again, at least for our initial microbiome study, is that the cohort of patients were very small or smaller, and so we didn't see a specific trend in what organisms were found. But again, when we think about diet, an individual on the SCD is not necessarily eating the same thing that another individual on the SCD is eating. The general foods are the same, but the specifics will vary, and that probably also varies the organisms that we see. One of the more interesting studies that we are doing, and Dr. Lee is leading this study, is a reversed EEN study, which we look at we get whole foods, blenderize that into a formula, and use that as EEN. And why that's really interesting is because there's just a limited number of foods that are in this formula, and we're seeing what happens to their microbiome before, and because there is just a small number, we're looking to see if there's going to be a similar shift, or even with the same foods, different shift depending on what organisms they started off with. So there's a lot of fun research going on. Yes.
Are you guys using EEN and then transitioning them to SCD after? And how do you do the percentage of it, like getting them back into the food versus?
Absolutely, and I think Heather Tweeble is going to talk a lot more about that. But again, it really depends on the patient and the situation. It's not one size always fits all, but we do for many individuals who have active moderate Crohn's disease, use EEN and then transition to the SCD. If the symptoms are milder or if it's ulcerative colitis, we will do SCD primary. And it also depends on the child. Some children can do EEN and it's not an issue, and other children won't. So, good. Other? Okay. Oh, yes.
You showed in one of your figures that part of what the dynamic between the immune system and the microbiome is the secretion of IgA into the lumen of the gut.
Mm-hmm.
Has anyone done any work characterizing the sort of secretome of the types of IgA, what those antibodies are, and how those change as the microbiome or the diet change?
Specifically in inflammatory bowel disease, or no. I mean, again, the secretory IgA is going to be based on what is being seen in the lumen, but nobody has, to my knowledge, has characterized that as of yet. Great. Okay. Thank you very much.